Hi, everybody. Welcome to 2021 and our first Genius Project of the year. I'm here with my co-host, Carolyn Van Dyken, and we are going to be working with our first presenter this year, which is Joe Tatta, and he is the author of the book, Radical Relief. And we have a new kind of rollout this year for our Genius Project in that we're going to be focusing a little bit more on clinicians that have actually made the leap, made the change, made the shift in their practice, and really overcame a lot of barriers and circumstances to create a practice that was much more reflective of what their clients really needed and what they wanted to nurture for them. So we're very excited to have Joe here as our first guest for 2021. And Joe, we would love it if you would take the reins and introduce yourself and let everybody know, for those who don't know you, who you are and what you've been up to.
Sure, Susan. Hi, Susan, Carolyn, and hello, everyone. It's great to be here, and Happy New Year if you're watching this for the first time for the new year. My name is Joe Tatta. I'm a physical therapist. I reside in New York City. I've been a physical therapist since 1997, so probably going on about 25 years, done lots of different things, which we'll probably talk about somewhere here today. But currently, I'm the founder of a company called the Integrative Pain Science Institute, and I focus on training professionals in biopsychosocial principles, as well as, of course, treating patients with those current approaches.
Excellent. Well, Joe, again, thank you so much for joining us. We really are excited to have this conversation with you and to learn a little bit more about your practice and where you've come from and where you've gone to in a more broad sort of biopsychosocial perspective. So why don't we jump right in and tell us a little bit about kind of where you started at the beginning of your journey in physical therapy and what your practice looked like and what kind of training you did in those early years.
Sure. I mean, the very, very beginning, going back to my first job, 1997, I worked in an inpatient multidisciplinary rehabilitation unit of a hospital here in New York City, a great community hospital, which was called St. Vincent's, a small hospital, which was really nice because the care and the staff was very intimate. That hospital no longer exists anymore, but they had a really wonderful program. And it absolutely had more of a chronic pain lean to it. When I first started practicing in 1997, that was right before many of the multidisciplinary chronic pain programs actually shut down. So I kind of came in on the tail end of that. So I had a little bit of here's what a multidisciplinary chronic pain setting looks like, but we're really kind of transitioning it more to a multidisciplinary rehab setting. So I did that for about 2 years. During that time, I also moonlighted in the hospital had an outpatient center as well. So got my hands wet and made some extra money in outpatient. Then I moved on to kind of what seems like a radical change, but wasn't so much a radical change with regard to the steps along learning a biopsychosocial approach. But I worked in a practice that was called Performing Arts Physical Therapy here in New York City. And we specialize in treating performers, mostly dancers, mostly Broadway dancers. So on any given day, probably about 80% of my schedule was performing artists, mostly performers, dancers. And that's when I really made the connection of someone can have what we would call or identify as very good, adequate, perfect strength, full range of motion, excellent coordination, even wonderfully beautiful movement, so to speak, but yet they can still have pain. And I really remember that point very clearly in my mind. There was a young dancer who came in. She was about 24 years old. When she walked into the PT gym, heads were just turning. I mean, she was just, kind of perfect epitome of a dancer, except she had chronic low back pain that she finally decided to go see a physician for. And the physician put on her prescription sacralization at L5-S1. Now, all of us know that the human body has many different types of bony anomalies, and a sacralization where the fifth vertebrae is somewhat connected to the sacrum via bone is something that happens quite frequently. And it doesn't necessarily have an impact on how someone moves or their function or even pain, but she was very focused on this because in her mind, and kind of thinking about where she comes from, the idea of losing range of motion in a part of your spine that you use, of course, for dance was very, distressing to her. So I did a lot of work with her around that concept. Now, this was before anything ever came up about pain neuroscience education, mindfulness, CBT, ACT, all that stuff even was, existed. But I think, I mean, both of you have probably practiced probably about as long as I have. So yes, we've studied these techniques, but we actually lived a lot of this before we actually had the data. So we became very fluid with talking about how, yes, there are physical aspects of the body that are important, but yet we have observed clinically, and don't forget, clinical observation is very, very important from an evidence-based perspective. We have all observed people with x-rays, MRIs, CAT scans, et cetera, who either had pain or didn't have pain, but yet showed a positive finding. So that was kind of the first aha moment, so to speak. The other interesting thing at that point in my life was the PT practice I worked at had a Pilates studio attached to it. And they actually had a Pilates training program there. So we would not only treat the patients who were dancers, but we would refer them on or send them on for Pilates at least once a week as a form of kind of return back to performing arts, if you will. Now, my background is I was a gymnast, so I was very interested in kind of this movement aspect of it. But so what I did was I went through that training. So I became certified in what they would call a traditional approach to Pilates. But as I went through that training, and this is included in a lot of Joseph Pilates' earlier work, is the mind-body connection.
Right.
How the mind influences movement,
Right.
how the mind influences your health, how the mind influences your body, how the mind influences your decisions. So I went through that, and that was one somewhat refreshing to me because the PT program I went to was wonderful. It was a little bit more sports and manual therapy oriented, which I enjoyed, and I fit into that silo. But I also had this gymnastics background, which gymnastics definitely has that performing arts background, and a lot of mindfulness is actually wrapped up in a lot of those different types of approaches as well. So that's how I kind of got involved a little bit more in like, okay, there's definitely a mind at work here with a body that's moving. And from there, I went on to open my own practice, and I followed that model. I had a PT part of the practice, as well as a Pilates studio. And then from there, I don't know what the really the next step was. If I think back to my mind, kind of these signposts. I think I began studying mindfulness or just taking a mindfulness class, just for my own health and interest.
It sounds like for you, maybe because of your background as a gymnast and just always your interest, that the mindfulness component has almost been there really from the beginning. Like that was almost a natural progression for you.
It is, and then when you start studying things like mindfulness and ACT, and they start putting a framework around things that you've experienced yourself, you start having these little, kind of aha moments. Like, oh, that's what I was experiencing when I was in this competition,
Right.
where you felt like you were very present in the moment, and equally in that competition where you couldn't be present in the moment and how your performance was.
Right. Right. Do you think, Joe, if you think back and reflect 15, 20 years ago, that was an unusual place to be as a physical therapist in sports and performance and in orthopedics? So even back then, that was really quite unusual.
Um, I've always been a little bit outside the kind of usual boundary, shall we say, and I actually kind of enjoy treading in those waters. But I think it was unusual for a physical therapist at that time. So this is
Yeah.
1999. It was unusual for a physical therapist to um, not only study Pilates, but actually actively integrate it into your practice.
Right.
And I wasn't the only one doing that at the time. There definitely were others, but it wasn't the way it is now, where there are
Right.
multiple training programs and
Right.
many different practitioners use it, and pro athletes are talking about it and things like that. So yeah, it was unusual,
Yeah.
and I can definitely tell you, people, would kind of like, turn their head to the side a little bit, like, what are you doing, and what is this, and what are these springs, and
Yeah.
what's with all this breathing,
Right.
that kind of stuff.
Right. Right. So
How do
how?
you measure it?
Yeah.
That was always big.
Yeah.
How do you measure it? How do you measure it? How do you record it? How do you write it in your notes?
That's right. That was a
Is
big
the
part of it.
story is the 1980s were the decade of mobilization. The 1990s was the decade of stabilization,
Mm,
Yep.
as bad as that word is, and then the 2000s was neural tension.
right.
So, but the mindset and coming from that difference is very telling, because I know out there, it's yoga and tai chi and qigong and Pilates and any type of movement that people want to do is not only recommended but widely accepted. Whereas in
Mm.
1995 to 1999, most people were not doing it. They were really biomechanical,
Yeah, and
in their
it's interesting
orientation
to
for care.
it's interesting for us as professionals who, on some level we kind of feel like we own movement, or
Mm.
we have some kind of expertise in the
Hmm.
movement science, so to speak. And it's interesting that we would look to these, more ancient contemplative practices. I mean, Joseph Pilates, it really invented his stuff in the middle of the century, so it was quite
Hmm.
old by that
Hmm.
time. But when you look back at his work, and he has books on this, like he studied yoga, he
Right.
studied all these different kind of contemplative approaches and weave them together. And I think, of course, he didn't have evidence-based medicine back then, but we can do that as professionals as well. We can pull from other aspects. And now that we have that evidence base and we know how to look at something with a critical eye, and we know how to kind of pick something apart and say, okay, I can see how this is working on both the biological, the psychological, and potentially even the bigger contextual social level, then we can pull that in an evidence-based way. And I think that's extremely beneficial for us.
Yeah.
Hmm.
It's interesting that I think where physiotherapy has often gained its legitimacy as we move through and into evidence-based practice is through sort of biomechanics, really, and a very biomechanistic approach. And, that has guided each of us in our clinical practices. And I'm sure you would reflect and say the same thing, Joe. But um, it's almost that we're being called away from that direction a little bit, like it's still going to form a component of it. And so how do we create some equilibrium around that? Because I think for a lot of physios that's a challenge, right? It's where do I leave the biomechanics behind and really look at the whole person? And yet you've been able to do that through most of your career, it sounds like.
Yeah, I mean, Karen, this is something I talk about all the time
Mhm.
with physical therapists that I interact with. I think we talk about it on the podcast that I have when I train PTs. We talk about it. It can be really difficult. I think this is another interesting thing that the three of us probably have in common is, since we've been practicing before this kind of new wave of, pain reconceptualization and cognitive behavioral interventions, in essence, we have kind of graded ourselves on the introduction of this. So over time, we have
Right.
slowly read
Mhm.
articles, we've slowly taken courses, we've slowly tried this information out. I really think right now, 2021 and going forward, you're going to see a major change with regard to multimodal care. And when I say multimodal care, I really mean two things: the promotion of exercise and physical activity, and psychologically based interventions that are together delivered by one practitioner.
Right.
So, not a multidisciplinary setting like I
Mhm.
started in, which they had that. The reason why it doesn't exist so widely in our country, unfortunately, is because insurance companies don't want to pay for it.
Mhm.
Hmm.
Now, with that, we had time to change, right? Just like we give our patients time to change. So, there's a little bit of setup for the therapist in the sense of, one, you're not changing your profession. You're not now becoming a
Right.
psychologist or a
No.
social worker.
No.
Um, Keep that in mind, but also keep in mind that you have been counseling people probably effectively in some way since the moment you came out of school, whether or not you went through school with a psychologically informed approach or not. So, for example, um, operant therapy or operant conditioning, what we do with the home exercise program, what we do with an exercise program, is really just a form of operant
Mm.
conditioning, or what they call operant therapy.
Right.
It's a time contingent, progressive contingent manner to move someone along in a behavior with
Mhm.
regard to what we're talking about, the behavior is exercise. So when
Right.
you work on a graded exercise program,
Mm-hmm.
which most of us probably didn't even have the terminology graded exercise program when we went through school. I know I didn't. We just called it an exercise progression.
Right.
Now it's graded exercise. So I think there's the mindset first, right? Of you're not switching careers. You don't have to do that. Um, I do think you have to somewhat invite in a part of you that you've already have been cultivating for a long time, but invite it in a little bit deeper. So that's the first part, kind of on a higher level aspect. The second, kind of more concrete, is, and this goes for anything, because in 10 years, we're going to be on psychologically informed care, we're going to be on something else.
Right.
Look at your current practice, which basically means look at your habits and pull out the interventions or the things that you're doing that don't have a whole lot of research, or your patients don't find useful, or you don't necessarily find to be very effective. Now, once you pull something out, right? So you pull out the hot pack, you pull out the ultrasound, maybe you pull out the manual therapy, depending on where the person is on their progression. There's definitely a place for manual therapy. Um, and then there's room to place in some of these interventions. So, for example, mindfulness, if that's what you want to use, there's many different psychosocial approaches. There's a really good meta-analysis, 2019, that looked at brief interventions of mindfulness,
Mm-hmm.
many different health conditions, including chronic pain, including obesity, including all the different things that we see in practice. And it showed that a single session of just 5 minutes of mindfulness was effective in promoting the psychological change that we'd like to see in patients, meaning it had an effect on depression, it had an effect on anxiety, it had an effect on stress, it had an effect on behavior change. So let's say as a PT, this is just one example, you see a patient for 30 minutes, you may open your treatment session with a mindfulness practice for just 5 minutes.
Mm-hmm.
Or maybe you close your PT session with a mindfulness practice for 5 minutes. There's lots of different ways to
Yeah.
do it, of course, but those are just kind of some of the things that we can talk about.
Susan, do you want to jump in and
Yeah,
talk a
I'd
little bit
like.
about using ACT? I think this is a great time to do that.
Yeah, this is perfect, and I love the where you brought this in from that study in 2019, because they've had a few studies that led up to 2019 looking at burnout in healthcare professionals, which this is the flip side of this work, right? Why do we burn out as healthcare professionals? Because we're not effective, and we're asked to be doing more and more of ineffective practice. Whereas this is showing that 5 minutes can not only change your practice, but can also change your patient's practice. And it's when people say, I'm so busy, there's no way I can do any of this stuff, I'm so busy. But 5 minutes is amazing what can happen in 5 minutes.
That's right. And I think, Susan, this is probably the most important part of our conversation today, because as professionals, we love to talk about research and what this study was like and what it showed, and this intervention versus that intervention. When you start to study things like ACT and mindfulness, they change you as a person. I think when we're talking about change as a person, really what we're talking about is, how does that impact the way I function as a licensed health professional, specifically within the realm of burnout? We know that burnout is so high amongst those of us that treat chronic pain. And when I look back, I actually wonder to myself, and this is even, I'm even starting to talk to some university professors about this. How can you release new professionals into the world right now to treat people with comorbid chronic pain, as well as mental health challenges, as well as all the societal challenges that we're all facing right now in 2021? Like, we can't just treat a joint anymore.
No.
And if you expect licensed health professionals with master's degrees and doctorate degrees to function like that, you will burn them out very rapidly. So these skills are so important to us as professionals to alleviate our own anxiety, our own depression, our own tension, our own burnout. And really what I find, like, especially with the model of psychological flexibility, which is part of ACT, which really teaches you that when you're working with a client, you're in this container with the client. So you and the patient, or you and the client, are in this container. And what you're seeing with the patient in some way is reflecting back on you. Now, what you do with that reflection and what you do with that experience the patient is having is something that we can talk about, because people who go through very biomechanically, biomedically oriented trainings, which I definitely did, and I can say I'm definitely guilty of this, probably for the first 10 years of working, a big part of my kind of, MO was to fix someone, was to, one, fix their pain. And then two, if I noticed someone was having what we now identify as maladaptive thoughts, I, in essence, would some way kind of like jump on them and try to stop them. Or try to convince the person that this is not what's happening. Now, since then, there have been people, David Butler, Lauren Mosley, Adrian Lowe, who have taken those principles and built out wonderful evidence-based ways to approach that with patients. However, every method, and I am a big proponent of pain neuroscience education, but every method has its limitations. So if we can't change a thought, if I can't change someone's belief, then I need some other evidence-based method tool to help the patient and potentially even help me with the uncomfortable thought that I have that I can't change this person's pain, yet I still have to work with them in some way for the next 4, 8, 12, 6 months, so to speak. So those are the things I actually love talking about more, and even exploring with practitioners, and even just kind of exploring, even in the literature, looking at that. And I really think that you really can't start to apply something like mindfulness or ACT unless you've applied it on yourself first. So you kind of have to live this a little bit before you start to use it.
And it comes down to, just even as I reflect back on what you're saying, sort of this shift in framework into this integrative medicine framework, right? Where we move away from this fixer-fixee kind of relationship, which we've all been trained in and feel very comfortable in, into this collaborative relationship. And within that collaborative relationship, you then need structural frameworks and conceptual frameworks like ACT, CBT, motivational interviewing, different strategies that you can then develop that collaborative relationship.
Yeah, it's important. I think it's useful to let people know there's lots of them. And just because my chosen approach is ACT, and I love ACT and I love mindfulness, it doesn't mean that I don't use a little bit of CBT here and there. Like you said, Carolyn, it's just the framework that I kind of now work from. I know, Carolyn, you've studied CBT extensively. You probably have that as your base, but over the years, you probably have learned to pull in other things that now has caused your CBT base to kind of grow and flourish.
Absolutely.
And it's important because I think if we look at, so if I, for example, if I asked you, how many exercises could you rattle off for a lumbar stabilization exercise? You probably have hundreds to thousands in your mind right now.
Sure.
It's the same thing with all these psychologically informed approaches. I think the most important part is choose one, spend some time with it, and develop some skill and expertise around there, so you feel good about it and you feel like it's impacted you in a positive way, and you've seen it impact your patients in a positive way. And then you can kind of start to evolve that either in your own way, in an evidence-based way, or learn from other methods out there.
It's so interesting because as we talk about psychologically informed practice, one of the things psychologists and social workers do all the time is they have supervised practice.
That's right.
They explore those concepts for themselves within their own lives, within their own practice, and apply it to themselves. And until you can do that, you really can't help someone else. And yet we are so hesitant as a profession to get into that supervised type of practice, aren't we?
Yeah, we are uncomfortable about that because it really would mean that I would have to say, I don't know enough. And here's the truth. There are millions and trillions of ways that the mind works. And every patient in front of you has their own unique learning history and experience and family history and pain experience. And just when you think you figured it out, someone's going to walk in
Yeah.
and they're going to surprise you, and they're going to cause you to kind of like step back a little bit and say, huh, I thought I had this figured out
Yeah.
and I don't. And I think the best practitioners say that quite willingly.
Yeah.
I know what I know, and I can also tell you what I don't know.
Mm-hmm.
And I'm willing to collaborate with other people or refer on to other people when I'm out of my sort of comfort zone or skill level, or recognize they need more acceptance and commitment therapy than what I have to offer them as my basics in that area, right?
Mm-hmm.
So
Yeah.
we don't do that well as a profession, I don't think either, particularly.
No,
We
and
want
I
to
have to
hold
tell
on.
you, I crave that actually.
Mm,
I crave that now because I realize there's so much in the realm of what we're doing with regard to behavior. And there, like I said, there's not one answer, but to find those professionals who really will say, yeah, I'll take an hour out of my Saturday where I don't have to, I'm not concerned about pay or anything. And I'm just going to open up and tell you what I know and share with you. And you tell me the same.
mhm,
And you talk about, what worked and what didn't work. And like you mentioned, mental health professionals are better at
mhm,
doing that.
mhm.
We have a long way to go in that realm.
Yeah.
Well, I think that part of what it is that our profession has, they crave that biomechanical knowledge because there's no uncertainty, or there's
Mhm,
less uncertain, I should say, less uncertainty there. And I think the discomfort comes in with the idea of uncertainty.
mhm,
I can't fix them, and what do I do if? What do I do if?
mhm,
What's going to happen if?
mhm,
And they're uncomfortable with the uncertainty. But what, I think you described it beautifully by talking about entering into the container with the client means that you're going to be in a shared type of situation where we talked about this earlier on the Genius Project with the development of the Therapeutic Alliance, and nothing but mindful listening and holding space in an empathetic way for that person, which has never probably been done for them in that way before.
Hmm.
And the power of just being able to share and listen and pay attention and actually say, that's new, that's interesting. This is going to be, I'm going to need to let this client guide me into the direction that they really, really want to go.
mhm,
And I need to share that narrative with them rather than come in on top like you talked about earlier.
mhm,
Okay, we're just going to fix this part. And then if they have that aberrant thinking that we call aberrant thinking, to them it's not aberrant thinking, it's the way their brain works, then we need to tell them that that's not necessarily, that's wrong.
mhm,
Yeah. What
That's, you can't think that way. That's not real. And it's like, for them it's very real. And it's not necessarily aberrant. It's a expression of everything that's gone on with them contextually.
That's right. And what's found in this type of stance that we're talking about for us as professionals is actually a lot of relief,
Mm-hmm.
because it can be extremely stressful to go to work 5 days a week
mhm,
and treat anywhere between 10 to 30 patients a day
Mm-hmm.
and think that I'm responsible for everyone's
mhm.
pain and health, if you will.
Right.
Mm-hmm.
And it's a completely different mindset and shift to think I'm actually not responsible for their health. There are definitely things I'm responsible for as a licensed practitioner, but I'm not responsible for their pain and I'm not responsible for their health. I'm here to help facilitate that process. And I'm here to facilitate the behavior change and the education that's needed and all the skills that are required. But there's a tremendous amount of relief that happens with that, because then you don't go home thinking, well, okay, I saw 10 patients today, but you know what? 8 out of the 10 are still complaining of pain 4 weeks later, which we know is likely to happen in people with chronic pain. Pain is oftentimes is the last thing that goes away,
Mhm,
not the
Mm-hmm.
first thing.
mhm,
If
mhm,
ever.
That's right, if ever.
Mm-hmm. But how does their life change?
That's right.
You
And that's
know.
what I'm interested in more and more. What I'm interested in more
Mm-hmm.
and more in talking to people about is I want to know about your life, and I want to know
Mm-hmm.
about, yes, you can tell me about your pain, and everyone's going to do that, whether you ask them to do it or not.
Mm-hmm.
But if you dig underneath someone's pain, there's pain there, but it's pain related to their life, not pain related to their
to the
body.
structure. Yeah.
And that's such an important point, and I really hope that everybody really listens to that, because it's the person's life experience that needs to be uh, honored more than anything else, because it's their experience and not what you would perceive for them. And the other thing is, Joe, as we kind of move forward and talk about this, can you talk a little bit about the shift between physical therapy, functional goals, and now within ACT and some of these other psychologically informed processes of the value-based goals? What's the difference, and how does that look?
So values is a process of ACT. There are 6 core processes in ACT, and values is one of them. The reason why values has gained so much attention is because there were a couple of studies that were completed, research studies by psychologists who are specialists in ACT. And what they found over the long term, they looked at like 3-year studies,
Mm.
that the impact on values or training values or helping connect people to their values was the one mediator of change. Even though pain may have not changed, when you worked on values, it influenced a lot of the other things that we're kind of going after, both in the sense of kind of the positive psychological change, such as acceptance. Acceptance is a positive psychological factor, if you will, as well as what we identify as the negative ones, like depression and anxiety. And we love to talk about those negative ones, catastrophizing and fear avoidance. But what I like about ACT is it really focuses more on the positive psychological variables. Because if I can't change any of that, any of those negative variables, or I can't change them directly, then something like values comes into play. And values is confusing to physical therapists when they first come to it, because we have goal setting so ingrained in us from day one. And values and goals are something that's very different. And actually, values is probably more important when you're working with that chronic pain population in the beginning, so to speak. I'm not saying goals don't have their place, they definitely do. But values may be the one thing that kind of like lights the spark under a flame that'll continue to burn well after they're out of your care.
And it's really those long-term changes that are going to be the true markers of effective care, right? And I think that's really why we're making the shift and starting to look at a more effective way of practicing.
Yeah, so when we look at values, values are like the horizon. So if you set sail on a boat right now on the sea and you're sailing toward that horizon, what you'll notice is you never get to the end of the horizon. There's no end point to it.
Mm-hmm.
And your values are like that as well. They continue throughout your whole life. Values may change,
Mm-hmm.
but values don't have an end point to them. Where a
Right.
goal, walking a block, lifting
Right.
10 pounds, um, losing 50 pounds, meditating for 10 minutes every day, those are goals.
Yeah.
Those are things you can check off your list. You achieve them, they're measurable, they're done. Once they're done, they go away. Where a value is always there.
Joe,
Goals are more like the stair steps.
That's right.
yeah.
The values are way out there, but there's ways to get there, and there's so many different ways to go. But I like that, because the values are the horizon. It's like the vision, where you want, and that values is such a great word, because it's what's important to you.
Yeah.
What do you value? Not what I value, not what Carolyn values, but what do you value?
Yeah,
And
I think goals have made us approach or facilitated us in some way to approach things from what we value,
mm-hmm.
Yeah.
what we think is important. And you may be shocked once you start really using values that you actually rapidly move away from goal setting and move a lot more toward values. And when I say move
Mm-hmm.
toward values and talking about values, it doesn't happen just in the first session. This happens probably over the course of many weeks, because as you get to know someone, as they get to know you, and hopefully that therapeutic relationship is opening up and growing, they tend to
Mm-hmm.
share more about who they
Mm-hmm.
are. They share more about what their dreams and vision are for themselves, or they're more easily able to connect to the
Mm-hmm.
values that they lost that were important to them. Because with pain, it's like all that focus, all that awareness is pinpointed on this one sensation, if you will. Now, if all your focus, right, if you're looking through a periscope just at pain, then you can't see everything else that's going on around you.
Mm-hmm.
And in essence, over time, it just drops off, it fades away. So there's a whole process of helping people reconnect to who and what's important to them. And it's more than just one session, one question, one exercise. Yeah, sure, sometimes people can contact it very rapidly, but for people who have had significant pain and it's been part of their entire life, when you look at people with early childhood experiences that have been aversive for them, it takes time to
Mm-hmm.
contact that, because there's also a little bit of pain in that as well,
Mm-hmm.
because somewhere in there there's been disappointment for them, where people have said, hey, take this medication and once your pain goes away, then you'll be able to return back to work. Or go for this dry needling, acupuncture, fill in the blank of any passive approach that we have, where people get really hooked into thinking that is the cure all, but yet it's really damaging to their self-efficacy, and with that they've lost all hope. However, right when you think people have lost hope, so when you're talking about values, this is what happens when you talk about values and really kind of dig down into values with people. You may see like this momentary, like just kind of like slump in the chair, because people start connecting to the things they remember. It's very moving and emotional for them.
Mm-hmm.
Now, you as a therapist have to ground yourself in that moment, right? Take a nice deep breath, plug yourself into that present moment, whether if you're sitting down, you're focusing on your sits bones in your pelvis. If you're standing, you're focusing on your feet, and realize within that moment of what you're seeing is a low moment, you're also seeing someone reconnect with some hopefulness that, oh, okay, we're now talking about things that I've lost. And it seems like he or she may have a way back to that for me. And that's what no one discusses with people.
Yeah.
And that's when you solidify a therapeutic relationship,
Yeah.
where people want to come back and see you. And there are ways that you can continue to nurture that. And it's really important that you do that.
Mm-hmm. Yeah,
Yeah.
the meaningfulness for people is like profound,
Yeah.
and
And people,
don't run over that.
I've had therapists say, well, when I did this, they started crying. And I'm like,
Right.
okay, that's part of emotion regulation.
Yeah.
Let that happen. Express empathy for them. It's even okay if you want to become a little teary-eyed and even shed a tear yourself. That's fine,
Mm-hmm.
as long as you're expressing emotion for them and you're not
Pitying them.
tapping into your own. You're
Yeah.
not pitting them,
Yeah.
or
Or
you're not
or
tapping
yeah,
into
it's
your
your
own
own thing.
sense of, oh, I have my own inadequacy that's showing up here. That happens as well. So there's a lot of bravery that happens
Yeah.
as a physical therapist, and you start to work with people in this way, because you're not throwing away all the other things you have as tools. You're just taking other tools that can help speed them up, so to speak.
Right. Well, Joe, I think that your ability to really clarify the shift in practice that needs to happen and your journey through that shift, clearly, I think if you think about your practice 25 years ago as a new grad, you've always had a bit of this framework. That's what I'm hearing from you, right? This was always a piece of who you are, and you gravitated towards that, but you also developed your biomechanical skills and all of those sort of typical manual therapy PT skills that we all identify with, but you grew from there, right? Which is amazing. Can you just, to wrap up, maybe just tell us a little bit about where your journey is taking you now and what sort of things are on your horizon as you move forward in your career?
Sure. I mean, all these topics are just, I'm so passionate about them, as you can probably tell, but I love training therapists on some of these skills. I have a new book out called Radical Relief. It talks about ACT and mindfulness specifically, and just a little bit of pain science in there, because we don't want to leave that out, but we want to learn to blend all these skills together. I have a couple papers that I have, fingers crossed, will be published in journals about some of this.
Congratulations.
Thank you. So
Mm-hmm.
that's on my list of things. But I just love these conversations, whether they're online or at conferences. So trying to spread this around as much as possible, just like you're doing. I think we all have a, kind of shared similar message. So it's refreshing to talk to you guys.
Amazing. Well, thank you so much for taking your time this afternoon to have a conversation with us. And we are going to open up this conversation to whoever wants to join us to have a chat with Joe and ourselves around how to make this shift. What are your barriers? What are your challenges? And we are going to do that. What was the date we decided on, Susan? February?
We decided on February 13th at 12 noon Eastern Standard Time. So if you're listening in from across the pond over in Europe and beyond, that hopefully we'll be able to capture a time that you can join us too. And we will be sending out links. So feel free to come to our website, thegeniusptproject.com, sign up on our website for the Zoom link and we will get it out to you. Follow us on Reframed Rehab social media, where we will also be putting information out. And of course, you can follow me at sclintonpt. And Joe, do you social media? We'll have you send out some links too so people can find.
I do. Everyone can find me. All my handles are pretty easy. It's at Dr. Joe Tatta. And of course, they can find me on the integrative pain science institute.com website.
Right. And all of Joe's information on where to find him and how to connect with him will be in our show notes.
Hey, and I was just thinking, can we do like a little brief exercise intervention tutorial when we meet?
Yes.
I think that's a great idea. Will you lead that for us? Yeah?
Yeah, that'd be fun.
Okay, let's start. Just as the research suggests, let's start with 5 minutes and then let's see where it takes us into just kind of being really honest with each other around our challenges, because it is a challenging change for us all, but it's so rewarding and so worth it. Yeah, amazing. Thank you, Joe. Thank you, Susan. And we will see you again on February 13th.
Thank you. See you soon.
All right. Take care. Bye-bye.